Well, I'm excited to welcome my good friend, Dr. Bernard Chang, to the podcast. Welcome, Bernard.
Hi, Debbie. It's great to see you, Dr.
Great to see
Sorensen.
you too, Dr. Chang. We joke because we went to graduate school together back in the day. We both got our PhDs in psychology together at Harvard. So we're reunited. And Bernard is now an emergency physician and psychologist and assistant professor of emergency medicine at Columbia University Department of Emergency Medicine in New York, and researches the health impact of healthcare provider stress. So really grateful to have you here because I think you know better than anybody what's going on with provider stress right now. So Bernard, after finishing your PhD in psychology, you out overachievered the rest of us by going to get your MD at Stanford. What values were behind your decision to choose to go into medicine?
So first of all, thanks so much, Debbie, for having me on here. I really am excited to kind of just talk with your audience and just chat with everybody for a few minutes. Aside from wanting to be like a lifetime student, I think for me, the main motivation for going to medical school was I did most of my research as a psychologist looking at schizophrenia and some of the more biological basis for disease. And what really touched me was looking at kind of when I was doing some of my research, kind of on the hospital wards, watching some of the clinicians, seeing the clinical psychologists and the physicians really at the bedside, really impacting patients directly. And it really got me excited about that. And I thought, wow, as much as I love research, I think having that direct patient contact was so profoundly like meaningful. Watching it from afar, that even though I knew it was going to take me a couple more years and a long route, I thought it was ultimately worth it to really be able to have that chance.
Well, thank you. I mean, I asked that question for a reason, which is that I think people usually go into healthcare, into medicine, because they care. There's something they care about in there, and there's something really important and meaning driven, mission driven about this work. And so, yeah, thank you for sharing that. I think that kind of underlies, I think, a lot of what we see with the impact of providers on
Yeah,
doing
no,
stressful work.
no, I agree. And I think one of the most challenging things in some ways is because I would say that the majority of folks who go into medicine or go into healthcare really are driven by some very positive sense of they want to have some type of positive impact on patients. And I think the really sad thing is seeing kind of like the psychological toll on providers and seeing themselves really affected or impacted by both the occupational stresses or kind of working in the system that ultimately that mission for trying to help people gets confounded or gets almost blurred with this sense of emotional exhaustion too. So I think it's a incredibly sad, incredibly alarming phenomenon that we see among healthcare providers who kind of go in really with the best of intentions.
Well, can you tell us a little bit more about what we're seeing? Like, what do we know about basically the rates of things like burnout, depression, even suicide within healthcare providers and physicians?
Yeah, so it's a really, so I don't want everything, all this to be bleak and scary, but I think just kind of starting out with some statistics probably might be help frame kind of the conversation from here. So looking at rates of burnout or occupational stress, so the way we describe burnout is really more this psychological exhaustion or emotional exhaustion from that you're attributing to your work environment. I know there's different terms for burnout, different ways of operationalizing it, but thinking about burnout like that, we see rates of burnout in healthcare providers, both physicians and nurses and other healthcare providers at significantly higher rates compared to other professional jobs. So for example, within the House of Medicine, acute care providers, emergency physicians report almost 60% of rates of burnout. And that's extraordinarily high. But then you frame that in the context of all medical specialties, almost 50% of providers report symptoms of burnout. I think this is very, very concerning that we see it early on too, that residents, like the house staff or the trainees, the folks who've just recently graduated from medical school, their rates of burnout are also similarly very high too. And so I think that this is a phenomenon that we're seeing that is both kind of pervasive within medicine, but then also starts early. I think from the standpoint of suicide, I think again, it's really one of the most tragic outcome from psychological stress that we're seeing among our healthcare providers. We see about 200 to 300 deaths by suicide by healthcare professionals each year. And physicians, unfortunately, have significantly higher rates of death by suicide compared to other peer professionals. When you look at the data within that, women physicians in particular have almost 140% chance of dying by suicide compared to peer professional women. And you see also a similar number with men at almost 40% higher rate of death by suicide. So I think the numbers are scary in the sense that I think the healthcare professionals are really vulnerable to burnout, and that there are severe consequences to this phenomenon we're seeing.
Absolutely. Absolutely. And it's more to know about so that people can reach out and get whatever support that they need. Yeah. So what you mentioned earlier, some stressors that play a role in this and that contribute to burnout, depression, etc. Can you talk a bit about some of the stressors that might be at play here specific to this profession?
Yeah, so I think that tackling apart burnout, you want to kind of conceptualize by a couple of different levels of analysis. So there are a lot of like what I would call individual factors, irrespective of the occupational health risks or stresses of medicine, such as individuals with their either individual stresses at home or a pre-existing history of mental health problems. But I think that what we're talking about today really is like the occupational stresses. And so the House of Medicine is a really unique endeavor or operation. You have folks who are working usually nonstop at a dysregulated working schedule where they're sometimes working days or nights. Their sleep schedules are all off keel. They're also being exposed to extraordinary levels of stress, not just from their sleep cycles, but also from the things that they're seeing at work, particularly among folks working in, say, the ICU or the emergency department, but then also even in the outpatient clinics. They're seeing folks coming in, their patients coming in, sometimes the most vulnerable points in their lives and telling them really tragic stories at times. And I think you can imagine that this can have some psychological stress also on the providers who are listening and trying to help these individuals. And then lastly, we're also seeing now this digital age of electronic health records and documentation. There's just clinicians are encountering tremendous amounts of documentation burden. That's what oftentimes colleagues will call it, where they're spending a lot of time in front of the computer rather than in front of the patient, really just kind of doing kind of those check marks. And I think that whole combination of stresses really can lead to some psychological distress among different providers.
Yeah, it's a lot to manage. Certainly, it's just heavy burden and a lot of stress that's sort of chronic over time. Now, there's also the issue of, I think, stigma within medicine. And I think that, to me, there's almost this view that it's not talked about that much. What do you think?
Yeah, no, I think it's a really great point. And we talked about this earlier before the recording about, I would say that here in New York, at least during the pandemic, we've been having these 7 o'clock healthcare or essential worker claps where people are essentially, it's really touching, speaking as a healthcare provider, people are clapping, you feel like kind of like a hero doing this. But what I say is like the kind of unhealthy flip side of that, the other end to that is that we don't talk about when heroes kind of stumble or where heroes feel vulnerable. And so there is, I think, this culture, even to date, within medicine and within healthcare providers, where you kind of want to be tough and you don't want to express certain types of weakness. And so I think there's really an underestimate of mental health stressors occurring within providers that we're not seeing in the literature today. And so we might be underreporting the number of stressors that people are feeling, as well as folks who probably would benefit from help, who are just not seeking help.
Well, this is where I really feel like the solution is, we were saying earlier, Bernard, is for our two worlds to come together, because I do think that clinical psychology and other mental health professions have something to offer here in terms of normalizing those emotions that people are feeling, and just normalizing that even heroes aren't immune from going through a tough time. In fact, that's what makes them courageous, right? Is just being able to face their vulnerabilities and their own emotions. And so I think, yeah, if people can learn more about this and kind of have the sense that it's normal to feel like this is hard and to go through burnout at times, it's what you do with it, might be helpful.
Yeah, no, I completely agree. And I think that, speaking as a psychologist, I mean, I'm not a clinical psychologist, but as a research psychologist and as a physician, I really have come, I have a tremendous amount of admiration for clinical psychologists, both in terms of their content expertise, but also the way that they try to kind of unpack some of the complexities of human distress and anxiety and depression, and how to kind of like approach that in a way to kind of improve outcomes. And I think I've always talked to like my physician colleagues who don't know that much about behavioral health or psychology, is that a lot of the interventions or the ways that clinical psychologists approach these challenges are in many ways similar also to our sisters and brothers in medicine too, in allopathic medicine, in that we really try to break down the chief complaints into kind of digestible, smaller parts, and really kind of unpack what's really kind of driving the root cause of it. And I think, having a recognition of that, our stresses or what we're feeling as providers is something that can be explored and can even be unpacked. And, with the help of some professionals, is something that is like very encouraging, I think.
Yes. And there are skills and, ways that you can get some help. Tell us a little bit about your research. You researched the health impact of stress on providers. What are you finding I know that this is a bit of a nutshell because it's probably complex, but what are you learning from your research?
Yeah, so what we look at is essentially working in the emergency department. I look at the impact of the acute care environment on both patients and providers. So what we've looked at before was the impact of, say, emergency department crowding and length of stay, et cetera, and how does that impact the development of acute stress in stroke patients and people who have had a heart attack. And so we've looked at those folks in like a small time capsule, like, one emergency department visit. And so I was really curious. I was like, well, what about the providers, the nurses, the docs, the transporters, the folks who are in the hospital setting, not just for like one day, but for like years on end? Does like does that environment really impact people's psychological well-being? And now, speaking as a health psychologist, does that impact their cardiovascular or autonomic nervous system? And so what we've been finding is that, lo and behold, it does. When you're having high periods of acuity in the emergency department or crowding, not only are you seeing increases in providers' subjective sense of distress, but you're also seeing elevated resting blood pressure. And what's interesting about that is that blood pressure, the time for it to kind of return back to like normal, is quite long. And so from looking at it from a heart standpoint, high blood pressure is a risk factor for developing cardiovascular disease. So one of the fears that I have is that, prolonged exposure, prolonged stress to this could also actually not be just harmful for your psychological health, but to your cardiovascular health. And so that's some of the projects we've been doing here. From a COVID standpoint, we've done some surveys now of the healthcare workers here locally at my institution at Columbia. And we found in a study of about 650 healthcare workers that the rates of acute stress are really high. We're talking about 60% right now, compared to usually with acute stress in our previous samples, we see rates of, maybe like 5%, if that, among some of the acute care workers, but we're seeing, extraordinary numbers from there. We're also seeing about 40% of our providers of that sample that we looked at having really bad insomnia or bad sleeping. And so we're finding that this event is really impacting not just your mental well health, but also kind of like your somatic, your physical health as well.
Wow. Yeah. So the high rates of how this is affecting people in the immediate aftermath. And I know you're right there in New York, which has been, a huge outbreak here in the US. Can you tell us just, the numbers support this? What are you seeing around you just anecdotally as you go through this over time?
Yeah, no, so it's really been surreal here in New York. I think now, I would say just thank goodness over the last few weeks, it's been a little bit more calm in the emergency department and just around. But I think I would say taking us back about 6 to 8 weeks ago, it was really just something I've been quite honestly was really unprepared for. I've done some work kind of outside of the United States, kind of working clinically, and it was a really surreal moment, I would say, about 8 weeks ago, where I felt like, you know what, I feel like I'm working in a disaster situation, but it's actually home. And that really um, kind of like resonated with me and kind of like really shook me. I think one of the challenges here that we've been seeing was, I think, kind of what I say like disaster medicine responses that on one level were just extraordinarily stressful, seeing people that were previously young and healthy dying, people, the rate of people coming into the emergency department so quick that you really couldn't keep up. Critical supplies that we've kind of taken for granted, really. Like an oxygen mask or a mask to protect yourself. That you all of a sudden were thinking about. Well, we've only got 5 left. What are we going to do with that? So I think some of those things were really just extraordinarily stressful. But I think probably for a lot of the other clinicians too, what was also really stressful was I never, whenever I come into work, even now, like there's always a risk coming into the emergency department that something might happen that um, you might have there's always some degree of harm to yourself. But I truly, in the height of the local peak here in New York, I really, every time I went to work, I really was scared that I would get really, really ill and really sick. And I think that fear of not just getting sick yourself, but also fear of bringing it home to your family was something that really was scary, not just for myself, but I think for a lot of my colleagues. And I think we saw, lots of my friends lived separate from their families during this period, and they weren't able to see a lot of their friends and families, and some of their families got sick too. And I think that whole situation of something like where work really was, you were surrounded by all of this, that really, I would say, really impacted all providers, not just all providers, but all individuals living around this area during this time, like in a really profound way.
Absolutely. I changed jobs at the VA here in Denver, but I was going into the hospital right when the pandemic happened. Is around the time right when everything started to shut down, was right around the time I was winding up there. And it's just hard to describe what it's like in those moments to just even go to work. It really gets your threat system going, your fight or flight system is activated. And there's so much uncertainty. I think it's a really heavy emotional toll. Bernard, thank you for the work that you're doing and for, being one of those people who shows up in this stressful situation for the benefit of all of us. I'm not trying to make you a hero here, but I do want to say that for you and everybody else who's listening, I'm so appreciative.
No, thank you, Debbie. And I think also thank you to your team as well too for giving me a chance to like chat with your listeners. And I'd also say too that I think with the type of work you're doing, this kind of this outreach is just absolutely critical. I think the more that we spend time talking about this and destigmatizing something like this, I think the better it can be for our healthcare workforce and just a general community. I always say that a healthy doctor, a healthy patient, that we really want to take care of the well-being of our healthcare providers, because I think they really are like the bedrock for our community. And I think we really just need to like kind of focus on taking care of like the providers out there. So thank you to everyone else, all the listeners too, as well, for kind of fighting the good fight.
Thank you, Dr. Chang.